So what we're doing is, since it is so expensive to have robotic surgery, to implement robotic surgery in low resource environments, like most of the countries in sub-Saharan Africa, we're using it with open surgery, which is not done very frequently in the US. So we're trying to take that technology that's used in robotic surgery and apply it to open laparotomies. Well, we're using the, Oculus Rift, and other than that, tele-mentoring device where we can observe, once the surgeons are trained, we can observe them from a distance and mentor them and monitor them. We can mentor them through something called telestration, where they will have a GoPro device as they're doing the surgery, a GoPro device on their foreheads as they're doing the surgery. And that will reflect on a monitor that's next to them in the operating room. That same picture will also reflect on the monitor of the mentor, so I can be a distance away. And if I see the surgeon, if I want to make a change in what they are, in a surgical maneuver they're about to make, I can draw a picture on my monitor and it will show up on his monitor, his or her monitor. And he or she will also have audio contact with me. So it's called visual reality, telesurgery, and tele-mentoring. It's trying to use applicable technology or resource applicable technology to advance cancer care in the developing world. What it really does is we're using technology to make up for the human resource gap. I think those things help, but it's nothing like having the actual surgical procedures there. So I think the education, the didactics is critical, and having it online is critical. But then the next step is having demonstrations of the surgical procedures and then being able to monitor and mentor those as the newly trained surgeon is performing those procedures. It's bringing all of the, big data and the newest technology that's now becoming cheaper and cheaper into environments where it's really needed to help close and fill in the human resource gap, because we just don't have enough surgeons, we don't have enough pathologists, so we could use similar technology, what they call telepathology, to help multiply pathology services without having a lot of pathologists around that are necessary for that to happen. We can train technicians to process the tissue on slides and then take pictures of those and then send them across the web to a pathologist who's sitting in a particular place. Much as like what's happening now with x-rays and mammography. A lot of the hospitals, for instance, in the United States are now downsizing. They're actually getting rid of radiologists because they're taking those pictures, digitizing them, and then sending them to a central place where the radiologist just sits and just reads x-rays. And he or she can be in India, they can be in Bangladesh, they can be in Russia, they can be anywhere. So every little hospital doesn't need to have a radiologist like they used to. That's right, it's important to train on site so that people can learn these procedures and know how they work in their environments. It's the difference. I wouldn't want to train a surgeon in the United States where he or she has every possible resource, intensive care units for complications after surgery, unlimited supply of blood products and anesthetic agents. That surgeon needs to learn those surgical procedures in an environment where she or he has a limited source of oxygen, anesthetic agents, blood, antibiotics, so he or she can make the proper clinical decisions based on the infrastructure that he or she has available to him. The initial virtual reality platform is being produced by a gaming institute in the US, and we've been working for probably 6 months. And I would venture to say probably in the middle of next year that platform should be complete, and then we'll start with the implementation of it in Zambia. So 6 months to a year. I think what I've learned most out of this conference, it has confirmed that the direction in which I'm moving is appropriate. As I said during my talk, there's been a lot of talk about how big the problem is, how difficult the problem is to solve of cancer control, cancer care in low resource environments. My philosophy is you start with what is available and you build on that. You make small steps. You implement. You start at the end and then work back towards the beginning. People always like to start by saying, well, you have to plan. You have to strategize. You have to make an assessment of what's available. Then once you do all of that, you have to get consensus from the stakeholders. Then you have to sit down and figure out how to implement things. People have been talking about that for years, and every time you come to a meeting like this, they're saying the same thing. My philosophy is, okay, we know all of that. We don't need to make that cake over again. What we need to do is take something small that we think is easily identifiable, feasible, and that can probably be implemented, and then study the impact that we've had. Come back and figure out how we could have done it better, what worked, what didn't work, why what worked, why what didn't work, but come up with a model, but get started. That way it gets you past the inertia of planning and strategizing. That's not saying that's not important, but at some point you have to take the dive. And my philosophy is take the dive, then come to a meeting like this, just like I just did, and say, this is what we did. It can happen. Let's get off the bench. Let's get started. And then make it better.